Good evening, everyone. It gives me great pleasure to welcome you to episode one of the JMitra Dengue Education Series, where we have a very senior doctor with us, Professor Ashok Rattan. He's going to be sharing his knowledge, his experience with us over the course of the next 2 to 3 episodes, next 2 to 3 webinars. This is a focused initiative to empower healthcare professionals with the latest insights and advancements in dengue diagnosis. Well, dengue continues to be a serious public health concern, especially during the monsoon months. The challenge lies not just in the treatment, but also in the timely detection, something that can significantly reduce complications and improve patient outcomes. Well, this three-part series that we're talking about has been carefully curated to take us on a progressive learning path from basic understanding to advanced diagnostic tools. So today's first episode, we start at the foundation with a clear and practical overview of dengue basics and point-of-care testing, including the role of rapid diagnostic tests and early detection. Well, to guide us through this essential topic, we are honored to have with us Professor Ashok Rattan, a distinguished figure in medical microbiology and diagnostics. He has decades of experience at the intersection of clinical science and diagnostic innovation, and has contributed heavily towards national health policy discussions, and also led some great work in infectious disease testing. As we begin this series, I urge you to make the most of this opportunity. Ask questions, take notes, and stay engaged. And don't worry, e-certificates will be issued to all participants. Without any further delay, let me hand it over to our esteemed speaker for the day, Professor Ashok Rattan. Sir, we're excited to learn from you. The virtual stage is all yours, sir.
Thank you, Arjun. Today, we will start with laboratory testing for dengue virus. This is the interim guidance which WHO has released. Dengue is a growing global public health concern. Over the past 2 decades, incidence has drastically increased. Globally, cases have been doubling every year since 2021. Dengue is being diagnosed in previously unaffected regions of the world due to global warming. In 2023, WHO declared dengue a global emergency and have launched a global surveillance dashboard. In 2024, there were 14.284 million cases and 10,000 deaths in 107 countries. There were only 75 countries which did not report any case of dengue. There is also DNDi, which has created a global partnership to tackle the problem. And according to them, there are 3.9 billion persons in the world are exposed to risk of dengue. 390 million infections occur every year, and dengue is endemic in 129 countries around the world. As you see here, initially dengue was known as a tropical infection because it is associated with the increase of a vector, which we'll discuss. And so that vector, as the vector can grow in greater regions, it can transmit infection in greater regions of the world. In India, there was a global study which has reported that between 1990 and 2019, the prevalence of dengue has increased from 0.9 per 100,000 population to 1.670 per 100,000 population. The number of the disability adjusted life years have also increased by about 40%. Dengue itself is a member of Orthoflavi genus in the Flaviviridae family. It is a RNA, single-stranded positive sense RNA virus, which is enclosed in three structural proteins, capsid, membrane, and envelope, and it has 7 non-structural proteins. It is classified into 4 distinct serotypes and many genotypes. But the serotypes are the ones that are of interest to us. Then infection with one dengue virus leads to lifelong immunity against that serotype. But only short-term cross-protection immunity against other serotypes, which lasts for a few months, and then it leads to more damage if you have a secondary infection, as I will demonstrate. So the dengue virus itself is 40 to 60 nanometer in size, and it has a genome of 11 kilobase, and these are the 10 proteins that are there, structural proteins and non-structural proteins and the functions that they. It is transmitted by a mosquito, which is also known as tiger mosquito, because it has stripes as you see in the picture. This is Aedes aegypti. Aedes means bad in Greek, so it is a bad aegypti, and albopictus in more temperate countries. In India, it is Aedes aegypti, which is the mosquito which transmits the infection. And on the right, I've shown you the pictures of the mosquito and how it sits. As you see in the bottom of the screen, Anopheles sits at an angle, and Anopheles will transmit malaria. But Aedes sits straight, and it has these stripes on its body. It grows in fresh water, and it stays near the habit. It can fly about half kilometer, and so it is near the habitat of persons. Only when fresh water is collected would it starts breeding, and 15 days or so after it has started, it will start transmitting the infection. It bites in the morning and at dusk. So Aedes mosquito not only transmits dengue, but also chikungunya, lymphatic filariasis, Rift Valley fever, yellow fever, which fortunately is not there in India, and of course Zika virus. And it's been suggested that more deaths occur as a consequence of the infections transmitted by the mosquitoes than by any other creature, including man. The clinical features are varied. It can be mild and completely asymptomatic. At the same time, it could be severe and can end fatally. The diagnosis based on clinical symptoms alone is unreliable due to the wide spectrum of non-specific symptoms during the febrile illness. There's primary infection and secondary dengue. Primary normally is milder. Secondary is the one which we should look out for. But of course, in biology, nothing is 100% this or that. So there are reports that primary can also be severe. Specific and sensitive diagnostic tools are available that are suitable during certain phases of diseases. So one size will not fit all. That would mean that you would have to find out how long the person has been sick or having fever and decide which test to use. So as I said, when a person has the first infection, that is known as the primary infection, and all four serotypes appear to be circulating. So once the first infection occurs, the person has either mild infection and then it will develop lifelong immunity against that serotype and only short-term immunity against the other three. It's when the second infection occurs, when the second time the person is exposed, and that is the time when serious illness can occur. In other ways, the first time infection really develops severe disease. Second time infection can lead to severe manifestation associated with fatality. This is an oversimplification, but yes, this is what is the understanding. And the current understanding is that this damage is because of antibody-dependent enhancement, which is the key factor in the pathogenesis. The antibiotic enhancement is that antibodies are produced that will lead to memory cells. And here you would find that the antibodies which are cross-reacting, instead of binding through the Fc receptor, it will bind through there's a fucosylation of IgG, and the virus will bind to the the virus will bind to the FAB portion, but the the antibodies will bind to the cell. As a consequence, the macrophages will engulf the virus and the virus will grow much higher in number and produce cytokines.
Plasma leakage is a process in which the protein-rich fluid component of the blood leaks from blood vessels into the surrounding tissue. Plasma leakage is the most serious complication that distinguishes dengue from severe dengue. For some dengue patients, as fever begins to disappear, severe dengue will develop.
So here, as you notice, that in secondary dengue, the NS1 binds to the toll-like receptors, and then it will bind to the antibodies, and the antibodies will attach itself to macrophages. As a consequence, the virus will enter and produce a large quantity of virus, and NS1 will be produced. This NS1 leads to leakage uh, of the plasma as well as destruction of platelets. This has also been suggested that it's a paradox. When we say dengue fever, actually the dangerous part is when the fever is subsiding rather than when the fever is at the peak. So diagnosis of dengue requires selecting appropriate laboratory methods based on the testing indication with their accuracy influenced by sample size, a sample type, stage of infection, prevalence of dengue in the region, co-infection, prior dengue virus infections, or other orthoflavivirus infections and vaccination history. Two vaccines are available, not yet available in India, but they are a toss-up on whether they will lead to protection or enhanced toxicity. Dengue can be detected in the plasma, in the whole blood, in the capillary blood, in urine and cerebrospinal fluid tissue samples, but serum is the preferred sample by the methods that we have at the moment. It is possible that as more sensitive methods become available, then non-invasive sample collection may be the norm for screening rather than using invasive methods. So there's three stages clinically. First, there's febrile stage, which is high fever, and there's the danger of dehydration and also thrombocytopenia. Then there is, when the fever subsides, then there's the critical phase, which is where plasma leakage occurs. There's also bleeding tendencies, and that is where shock can occur as a consequence of leakage of plasma. If a person survives through this critical phase, then there's recovery, and the recovery is also dangerous because the fluid which has gone into the extrastitial space would now be reabsorbed. So there could be overload of fluid that should be guarded against. In primary dengue infection, after the mosquito bite, the first part would be that the virus RNA can be found in various tissues, including blood. Since NS1 is part of the RNA, and as RNA multiplies, NS1 will be produced. After a few days, the viral RNA will disappear, but NS1 will still persist for 1 or 2 days more. About the fourth day or so, the antibody IgM will start appearing. It will peak in 2 weeks' time, and it will last for about 3 months. By the 10th day or thereabouts, you would have IgG antibodies. These IgG antibodies will keep on rising, and it will persist for a long time. If a person has a secondary infection, a second infection, mosquito bite is there, then the viral RNA would be again detectable very quickly, but NS1 will be produced, but it will combine with IgG, which is present, and would be clear faster. So NS1 would combine with IgG, which is present, and so its detection may be less and clearance may be faster. IgM may or may not appear, while IgG will be of high level. So the detection of IgG along with NS1 or IgG along with viral RNA indicates that it is the secondary infection, and it is on 3rd to 8th day that shock and hemorrhage can occur when the fever has subsided. So if you want to diagnose in the acute phase, that would mean that in the history, you must be specific with the patient on how many days since when has the fever increased, because this is acute rise in fever. In the first 7 days post appearance of symptoms, the virus can be detected, RNA can be detected, the virus can be cultured, or which is not normally done nowadays, but nucleic acid can be detected by doing an RT-PCR, and it's possible to detect low quantity of the virus. Then there is also NS1 antigen, which is present from day 1 and which will last for about 7 days. A virus will be detected for about 5 days. It will be detected 1 or 2 days before a person has fever, and would to be detected for 5 days. While NS1 would be detected from the first day of fever, and it will last for 1 or 2 days after the clearance of the virus normally. But as it's been suggested by the WHO bulletin, is that in primary infection, it lasts for 9 days after symptom onset and for 6 days in secondary infection. As I explained, that there's already IgG present. So when NS1 will be formed, there will be also complex formation, and it will be released faster, and it will be at lower titer. But because NS1 is there and it will cause leakage of the capillaries, there is chances of shock and there's chances of bleeding tendency. And I've already mentioned that though the virus can grow in cell lines, culture nowadays is rarely performed except as a diagnostic tool, except for reference labs. Next slide, please. Oh, sorry, I'm changing it myself. Okay. If there's more than 7 days have passed, then neither will virus be present, nor will NS1 be present. So here you have to rely on serological methods, and either by ELISA, which is more sensitive, or a rapid test, you can look for IgM. And normally both IgM and IgG is detected because they suggest that if you can detect the levels of both, and if you find that IgM is more than IgG, then it's likely to be the primary infection. While if IgG is more than IgM, then it is secondary infection. Whenever you deal with serology, ideally it should be paired samples. But of course, in clinical situation, it is not possible to get two samples with 2 weeks apart. Then it doesn't serve any purpose, though classically that is what the teaching is. For surveillance purposes, then the virus might need to be more characterized, and plaque reduction neutralization test to quantify the serotype specific neutralizing antibodies would be useful. Because multiplex PCR can be done to find out what serotype is circulating, and next generation sequencing can further characterize the virus so that you can then trace whether the same virus is causing the infection or different viruses are circulating in there. So to repeat once again, in primary infection, viral RNA and NS1 antigens are detectable in the acute phase, while IgM will peak around 2 weeks. It will appear about 4 days or so, and IgG will appear later and will persist. On the other hand, in secondary infection, the IgG will already be present. That will rise faster. Viral RNA will appear as in the past with the primary one. NS1 will also appear, but NS1 level will be lower and it will be cleared faster. 6 days is what is suggested, and IgM may or may not be present. So it's again to make it clear to you that there are 3 phases. First phase is the high fever phase, which starts with the appearance of fever, which can be high and last for about 3 days or so. The risk here is dehydration and starting of coagulation. Once the fever, during this time, the virus can be detected and NS1 can be detected. Once the fever subsides or begins to subside, then the virus is not detectable, NS1 may or may not be detectable, and IgM starts becoming detectable. This is the time. So instead of feeling safe here, this is the critical period where shock and bleeding and organ impairment can occur. This is where you should be in the hospital so that you can be resuscitated better and managed better. If you are not in the hospital or if there's difficulty in getting admission, that's the time when problem can occur. After a person has been taken through this critical phase, then is the time for recovery where reabsorption of fluid takes place. So we have to guard against protection from a fluid overload. So dengue virus infection is actually a self-limiting febrile illness. with symptoms ranging from asymptomatic to severe multi-organ dysfunction. It is estimated that 40 to 80% of infections caused by dengue are asymptomatic, and fewer than 5% of all dengue patients develop severe life-threatening conditions. Severe dengue can manifest in both primary and secondary infection. However, the likelihood of severe disease may be elevated in secondary infections due to antibody-dependent enhancement. Each one of us have a duty to perform civic duties to protect ourselves from bites, because there's no specific treatment available and there is no vaccine licensed in India at the moment, though two vaccines are making the round. Sooner or later, they will also come in India. But I think the health authorities are aware that it can cause more trouble than good. So we need to be careful about the virus. At the moment, we should be careful about the diagnosis. So WHO has clearly mentioned that instead of just saying dengue virus infection, we should say whether this dengue infection is a suspected case or a probable case or a confirmed case. Due to the lack of specificity of clinical diagnosis, laboratory confirmation is necessary to definitely diagnose dengue infection. So dengue cannot be diagnosed and confirmed on clinical grounds alone. So some test is essential to make a diagnosis of dengue. On clinical grounds, dengue has been divided into dengue without warning signs, dengue with warning signs, and severe dengue. The warning signs are what everybody should be aware of, so that you can look out for the warning signs and must stop doing home treatment and must go to the hospital while the fever is still high. And if you have persistent nausea and vomiting, if there's rash, if there's aches and pains, if the tourniquet test is positive, as if there's leukopenia, if the blood CBC has been tested, these are all warning signs, which could also be abdominal pain or tenderness, persistent vomiting, features of fluid accumulation, mucosal bleeding, lethargy or restlessness, and laboratories indicate that the rapid test is positive and the platelets are decreasing. These are all warning signs where you must be in the hospital. So again, this is to bring home the fact that dengue is an acute febrile illness where there is fever for 3 days or so, but that is the acute phase. The danger at that time is dehydration. The virus is present. As the virus disappears, you would find that the fever also decreases. NS1 is still present, but this is the time which is the critical phase, where bleeding can occur because the platelets have decreased drastically, or there is shock because the capillaries have started leaking fluid, and so there would be decrease and there is shock. That is the time when you must be in the hospital. After fluids have been given, and since there is no specific treatment, it is only fluid replacement and platelets to be transfused if there's decrease in platelet. Every unit will increase by about 5,000 platelets. And after 3 or 4 days of this critical phase would be a phase of recovery when the chance there is to be the risk is for reabsorption and fluid overload. Once that is taken care of, everything else is uneventful. This is again suggesting the same, that coagulopathy risk is always there, but the biggest risk is during critical phase where where hemorrhagic fever can occur, and that will be dengue hemorrhagic fever will be because the platelets have decreased drastically, or there would be dengue shock syndrome in case there's leakage of fluid. WHO has again mentioned these criteria to monitor, to be sure that you can identify and recognize when serious condition is occurring. The characteristics of an ideal dengue test, and of course, the diagnostics tests used all over the world are different. So each country has to weigh out what would be useful and what will not be useful. The characteristics of an ideal dengue test will depend upon what is the purpose you want to use it for. The three purposes are: one is for diagnosis, which normal persons will use. Surveillance is what the program will use because they want to know what is the burden of disease. And then the third is vaccine efficacy. So the same test will not be used for all the three conditions. The early diagnostics, for early diagnosis, you want to distinguish between dengue and other diseases with similar clinical presentation. These are known as tropical fevers, and something similar. Some features are similar in malaria, in leptospira, in typhoid, in typhus, and chikungunya. So all these conditions must be investigated in case a person is not dengue positive. The second one is that it should be highly sensitive during the acute stage of infection. It should provide rapid results. It should be inexpensive. It should be easy to use, stable at room temperature, stable at temperature greater than 30 degrees Celsius for the field use, so that there's no need for refrigerant. It should be able to identify all four serotypes of the virus. It should differentiate between primary and secondary infection, and can be detected in non-invasive samples like saliva or urine. That will be the wish list for an early diagnostic test. For epidemiological purpose, first priority will be it should be positive as soon as possible after onset of symptoms to provide early warning, highly specific, determine dengue serotypes, because it's good to know which serotype is circulating, though from all accounts, all four serotypes circulate at the same time. The second priority is to distinguish between primary and secondary infection. There should be high throughput capacity because during outbreaks, the hospitals are filled to capacity. So the number of samples coming to the lab will be huge, as you've seen during COVID time. Then but dengue doesn't occur every year. It seems to skip a few years sometimes, and then it'll come out with a vengeance. So it is a long shelf life, and it should be for surveillance. If you have non-invasive samples, that should be explored. For vaccine efficacy, you want to test to achieve primary endpoint, that is provide virological diagnosis of dengue virus infection during the febrile phase test to achieve secondary endpoints, distinguish between dengue and other flaviviruses, distinguish between dengue serotypes, distinguishes between first and subsequent infections, and provides correlate of infections, is a marker of severe disease and easy to use. So the algorithm, again, different algorithms are used differently in different parts of the world. In India, what they have suggested is that maybe when we have suspected dengue, first thing we must ask is, since when have the fever come? If it is less than 7 days, then we should either do RT-PCR or we should do a NS1. NS1 could be by rapid test or could be ELISA. If they are positive, then nothing else that is confirmed. If it is more than 7 days, then we can do NS1 IgM, either rapid test or ELISA, or and then we can confirm if it is positive. If it is more than 7 days, then we should use IgM, ELISA, or rapid test, because by that time NS1 would have disappeared. And if it is positive, then it is there. And if it is negative, then we should look for the other 5 conditions that are indicated. So the list of pathogens to be considered in the differential diagnosis is huge, but looking at what affects here and what was listed by the Indian Association of Critical Care Physicians, who said that persons with the malaria, dengue, typhoid, scrub typhus, chikungunya, leptospira can all present as undifferentiated acute fever to the ICU. So they would like to distinguish between these 6, and there should be tests which could tell within half an hour which of these infections is occurring. As I've already indicated, the virus can be found in the serum, in the plasma, in the whole blood, in the capillaries, in the urine, and in the CSF. And this is how you collect and how much you should collect and then submit. If you're doing a clinical study, then it's best to collect all of them, because as I've been repeatedly saying, at this moment we use serum, but ideally we should get a test which would be useful even in non-invasive samples, which will be very useful for children, because even infants are susceptible. So in the methods that are available, RN detection is by nucleic acid amplification test. This is the test is indicated for patient management and surveillance. Advantages are it's highly specific and sensitive. It gives results within the day. And there is also now point of care, near point of care tests available, which is cartridge based. Is possible to automate to increase testing throughput, can identify specific serotypes. Its limitations are it's only detectable in acute phase between 0 to 7 days. So do not attempt to give PCR if a person has already been sick for more than 7 days or even 5 days. Require higher volume of serum in the sample, at least half ml, compared to serological test, which may be done with a drop of blood, as you will notice, or at least 100 microliter. Require appropriate facilities and trained staff. Potential fall positive due to contamination. Does not distinguish between primary and secondary infections, and it is affected by inadequate transport and sample storage conditions. This is one example of a cartridge-based test, and they have 2 types of cartridges. One is arbovirus, which will detect all the viruses that occurs, as you notice here: dengue 1, 2, 3, 4, Zika, chikungunya, yellow fever, and West Nile fever. Or you can have only dengue 1 to 4, and the process is simple. You take the blood sample, put it in, and wait for half an hour, for a few minutes, and then you get a positive result. Whether 1 is present, 2 is present, and others are negative. Next generation sequencing, I think people are getting more used to getting this into. This is not a diagnostic test. It is for surveillance and further characterization, so that to understand the epidemiology and to take appropriate public health precautions. The rapid test, NS1 antigen test, which is the rapid diagnostic test, is the one which is highly recommended. This is recommended now even by the WHO in the interim guideline, though Indian health authorities seems to not like the test. But the advantage is that it will help in patient management and outbreak investigation. The advantages are NS1 is highly conserved. There's low risk of virus evolution affecting epitopes. It's easy to perform and can be performed at point of care testing. And of course, now there's also self-test NS1, which has been made available. Can use capillary or finger-pricked whole blood. It gives results in 15 to 30 minutes. The limitations are it's only detectable in the acute phase. That means the first 7 days. It's lower sensitivity than NAT or ELISA, and its potential to give false negative with secondary infections, because in secondary infections, because there's presence of IgG, the level of NS1 could be slightly lower. This is the test that is there as self-test. We will discuss this in greater detail and the need why it should be done in the next webinar. But suffice it to say at the moment that this is available for an individual to do it himself. What is required is just take a drop of blood, put a drop of buffer, wait for 20 minutes. If you get both lines, that means it's positive. If there's only the control line, that is negative. If anything else, it is an invalid test. So it's simple to identify. NS1 antigen ELISA is used for patient management and outbreak investigation. It is high, and as I've already mentioned, NS1 is highly conserved. There's low risk of missing the virus. It is higher sensitivity and specificity. The limitation is that only detects in acute phase. It requires venous blood and sample to be transported to the laboratory. Potential false negative in secondary infections. Then requires qualified and skilled personnel. One of the problem we noticed was that since it's labor intensive, normally it is done as a batch test, so that you start around 2 o'clock so that you can give the results by 6. So if a sample comes in between, you cannot accommodate it. Then turnaround time can extend to several days if laboratory has limited testing capacity or when specimens require referral, potential delay in diagnosis, accuracy, performance, and ease of use vary depending upon the brand and manufacturer. A combination of NS1 and IgM rapid diagnostic tests is good for patient management especially when you're not sure about the patient is not sure about how long the fever has been. So whenever there's any doubt, then instead of using one either NS1 or IgM, a combo test is the one which is recommended. It will improve the sensitivity compared with single analyte test, easy to perform, as you've seen, and point of care testing is available, can use capillary or finger prick test, and available in 30 minutes time. They say the performance has not been sufficiently evaluated and may vary depending upon epidemiological context. But I remember in 2011, there was a huge outbreak in Singapore where because of the outbreak, people were doing culture, they were doing IgM, they were doing immunofluorescence, they were doing PCR, and they were doing rapid test. This is the DUO test. And they found that DUO test performed equally well as far as the others. So that was the time. And the advantage was that it will give you results in 20 minutes time so that you can take a decision on what is to be done with those who are positive or those who are negative. Then it is possible to combine NS1 and IgM by ELISA is separate. Then it's improved sensitivity, it's a reduced risk of false positivity. But if you look, and some reports indicate that ELISA gives you as good results as detection by RT-PCR. There is IgM and IgG antibody available. It's easy to perform as point of care testing, and the advantage will be that if IgM is high level, that means it's recent infection. If IgG is high, that would mean it's an old infection. Again, you could do ELISA for IgM or IgG. Then a print test is used to characterize. It's not a diagnostic test. It is done in reference labs, and it's to find out whether serotype-specific neutralizing antibodies are present. And it will differentiate between cross-reacting samples. It will require convalescent samples. It's laborious and time-consuming, and it is done only in reference labs. This is how the virus, how the plaque reduction test occurs. So the recommended test method and interpretation results at different stage of dengue virus would be that in acute phase, you either look for RNA of the virus or NS1 by either the nucleic acid amplification test, rapid test, or by ELISA. After the 7 days are passed, the best recommended is you do NS1 and IgM. And after more than 7 days have passed, then you should do IgM only, because by that time NS1 would have disappeared. Since we've been using ELISA all the time, I would like to inform you that benchtop chemiluminescence methods are available, and analytes with chemiluminescence CLIA are available. And as you notice here, the detection limit is in 1 picogram. So if ELISA will pick up 500 picograms, chemiluminescence or CLIA would pick up 1 picogram. And I would suggest that maybe it will be possible to take, instead of blood, to take urine or saliva and use chemiluminescence, and to be able to screen for the presence of dengue, especially in children. It may be very useful. Since the machines are available and since the kits are available, I'm sure more and more research is required, since India is an endemic area for dengue, but at the moment it's still in the nascent stage. So the advantage of chemiluminescence over ELISA is that while the sensitivity of ELISA is good, the sensitivity of CLIA is excellent. Specificity is high. For CLIA, it is excellent. Dynamic range is moderate. For CLIA, it is broad. So you don't have to redilute the sample anytime. Then automation is normally ELISA is manual or semi-automated. CLIA is fully automated. Turnaround time is 3 to 5 hours for ELISA. It's rapid, usually 30 minutes for CLIA. Batching is mostly required for ELISA. It's not necessary. Random access, which would occur in a lab where you or in a hospital lab where urgent samples keep coming, is possible in case of CLIA, but not possible in case of ELISA. Operator dependency is more in ELISA, is low in CLIA because it is automated. Result stability is low in ELISA because it has to be read soon after it is finished, while they are stable and there's computer printout there. And equipment is reagent cost, etc. in ELISA is low, but CLIA it is higher. That is only the disadvantage. And I would recommend that the government of India does all its results based on CLIA rather than on ELISA. And in busy labs, CLIA is something which would be better than using ELISA, which can give variable results. So when you are selecting which test to use, there are various parameters. You looked at the methodology, you look at the performance, you look at the ease of use, storage and shelf life, quality of product and registration, and cost effectiveness. We normally stop at only cost rather than the cost effectiveness. And I think cost effectiveness is where we would need persons who are more financially savvy than the biologist to be able to really help us decide which test should be performed. Besides these specific tests, there are auxiliary tests which are also essential. One is complete blood count, in which I mentioned repeatedly that platelets decrease. If the platelets decrease tremendously, then there is risk that there will be hemorrhages. Various doctors have their own parameters. Some say 50,000, some say 20,000, some will even go to 10,000 per microliter. But it's an individual own exercise that if the platelets are below that, you should be careful. But yes, in dengue, platelets are very susceptible to decrease, and you must monitor the moment you have made a diagnosis of a dengue. You should be on the lookout for platelets, a decrease in platelets, because that will lead to hemorrhage. Hemorrhages in the skin you can see, but hemorrhages in the internal organs can be fatal. So this is what you need to be careful about. The second one is packed cell volume. As I had indicated, that the capillaries start leaking. If the capillary is leaking, then the packed cell volume will increase so that the hematocrit will go up. And that will be, the clinical signs will be that the mouth will start becoming dry, the armpits are dry, the urine output will decrease, and in the lab you will find that the packed cell volumes is increasing. This means that a person is losing fluid, and this is that the person is in shock. There'll be cold and clammy skin, and the person will survive only if it is in the hospital. It's also the dengue virus also affects the liver, and AST and ALT are important. There was one study which was carried out in Vietnam by scientists from Australia, about 7,000 cases or so. And they found that after examining hundreds of parameters, they found four parameters which could be of importance. One was whether NS1 was present or not. Second one was whether a person is vomiting or not. The third was what is the number of platelets per microliter. And the fourth was that how much AST, by how many times AST has increased over the normal, which is at 40. 40 is taken as the limit. So what is the AST level? And looking at these four parameters, as I said, vomiting, NS1 positivity, platelet count, and AST X, how many how many times above that, they had given a nomogram where different points were given. And looking at that, they predicted that if a person has more than 35% risk, then the person must be admitted. If you admit a person who has 35% risk, then the negative predictive value is 99%. That means anybody whom you allow the person to go home will not have any problem. But everybody whom you keep in the hospital, not everybody would have severe dengue. So the positive predictive value was 10%, but the negative predictive value is 99%. So if you are a doctor sitting in the emergency room, this would be a good triage, because this will make sure that your hospital is full of persons who deserve extra attention, and nobody who was safe, who was not, sorry, nobody who was not safe has been allowed to go home, so that there'll be no surprises. You would like to err on the side of caution. So you have admitted everybody whom you feel had risk, but not everybody will go in for severe dengue. But everybody whom you said to go home will remain safe. That is what this bears out. And this is how you do. You, if a patient is vomiting, you give him points. Sorry, if a patient is vomiting, you give him points. Then you give him points for platelet count of 100,000 per microliter. NS1 is positive. Then you find this 134, that's 35%. So if you let him go at above 35%, you should keep the person in the hospital. So dengue has been considered as 10 threats of global health in 2019. Evaluating the performance of common reference laboratory tests for acute dengue diagnosis, a systemic review and meta-analysis of RT-PCR, NS1 ELISA, and IgM ELISA has recently been published, and they have indicated that prompt identification of dengue virus can guide clinical management and outbreak response. Yet, laboratory diagnosis is complex, costly, and lacks consensus on performance evaluation. This interim guidelines, which I've explained to you, by WHO synthesizes current evidence on dengue virus infection, laboratory testing, and diagnostics. It is intended to provide practical and useful guidance to laboratories, countries, and stakeholders implementing dengue diagnostics in the context of the global emergency. So while I thank you for your attention, I would be dealing with home testing and the need for self-testing in the next webinar. I hope to see you then. If there are any questions, please feel free to ask, and we'll see if we can address those issues.
Professor Rattan, thank you so much. That was extremely detailed and very, very. I think you've taken the subject and made it taken it apart threadbare. Right till the core. Core issues have been addressed. There is a question, however, that's come from one of our attendees, Dr. Nagabhushan from Money Labs in Money Micro Labs in Coimbatore. His question goes something like this. Many doctors wanted me to test anti-dengue tests on ELISA method and not by ELFA method, alpha method. How do I convince them that in both the methods, the principle is the same and only the final detection mode is different?
Ultimately, it's trust. A person, as I said, Government of India also says they want ELISA, which is batch testing. So, and I did discuss with people in NCDC. In the program, they are looking at definity. While when you're taking care of patient, you want to quickly diagnose and take action. So I think the need of surveillance must differ from the need for diagnostics, and that is why we would discuss in the next why NS1 will do. But yes, uh, as I've tried to indicate, instead of ELISA, we should be doing chemiluminescence, which is better. But of course, if the Money Lab specializes in molecular biology, and if they are looking at PCR, then PCR is positive in the first week, where ELISA will not work, and
Absolutely.
and later on, ELISA is so it depends on what is your purpose. If your purpose is diagnosis, then you must find out what is the stage of illness, how many days the person has been sick before you have taken a sample, and that will decide which test to use.
Okay. There was another thing I observed, especially with respect to chemiluminescence. Now, chemiluminescence is always measured in RLUs, the eventually it's in relative light units. Is it possible to get a quantitative analysis of, let's say, an NS1 test, right? Because you have the results which are normally in nanogram per ml or picogram per ml. Can they be quantified? And if so, is there any correlation with amount? Is there a quantitative, how do I put it? Is it possible to quantify dengue NS1 testing? And if so, does it affect the course of treatment, sir?
See, chemiluminescence has recently become available. So not much study is available, but yes, we know that NS1, the higher the NS1, the more is the damage. So the higher level of NS1 would indicate that that the person is going in for severe dengue. So but that is possible if it is done in the first week, because quantitation of NS1 would be I would think that the right place for NS1 clear would be the urine, and I can imagine children being subjected, because even neonates can suffer from, if the mother has had dengue and has passed on IgG to the neonates, then neonates can have secondary dengue, and that would be very dangerous. So, if we can get the testing of non-invasive samples like urine, that would make by using a very sensitive method, that would make diagnostics very easy.
Okay, sir. And okay, but if you're talking about quantitative testing, is it relevant in the to know, even though the NS1 is strongest in the first week, in fact, in the first few days, it is the strongest. It is at the high, it's at a peak. Uh,
Yeah.
does it make an impact on the way the treatment is done?
No, treatment is non-specific, and treatment is non-specific at the moment. Though there was evidence recently, there was a paper uh, in uh, in Nature that domperidone has activity against NS1 and the envelope protein. So domperidone may have effectivity against the early stages of the virus, of dengue virus.
You also
But
mentioned, sorry, please go on.
and of course there is also, I think, AB1. NIH has made monoclonal antibodies also, which is in various stages of trial. But vaccine has there have been two vaccines which have been licensed. The first one was Sanofi's, which has not been withdrawn, but there have been some toxicity in the sense that antibody uh, enhancement activity noticed in that, while the other one is by Takeda, which seems to be safer, but only time will show whether it can be given to those who are naive, or it can be given to those who have had first infection.
Yeah, because you mentioned the Sanofi vaccine, and it was very interesting that it's called, I think it's called Dengvaxia or something of that sort.
Yeah.
Right? And they've had a lot of controversies after its introduction. So is that why it's not coming to India, or do you think there's any other reason behind
Yes,
that?
I think it's not been withdrawn, but it is not, and it's been licensed in many places, but not used anymore. So it's Takeda's 003, which is based on yellow fever backbone. But after that, see, what is essential is that when you have antibodies, they must be effective against all four viruses, so that the vaccine must produce a robust protection against all four. If it protects against three and you're susceptible to the fourth, that is where you would have antibody enhanced uh, toxicity. So
You
that is where the damage will occur.
So when a vaccine happens, I mean, you are basically putting in cells into the body. So does it have an impact on people who are basically seronegative? Does it impact doesn't it increase the risk for them? Any
No,
vaccine?
if it is, see, if you're protected against all four, then there's no problem. What you want is that you should be protected simultaneously against all four serotypes.
Right.
If you're protected against two or three, then you are still at increased risk.
Right.
Then it depends on whether, if you have already had one virus and then you take the vaccine, what will happen? Only, I think, clinical trials will show what can happen if you have already had a primary infection and then you take the second. That is where more work was done during using the rapid test, because before giving the vaccine, you had to first quickly find out whether a person has exposure or not had exposure.
Right. Well, thank you, Dr. Rattan. We look forward to the episode 2, where we'll talk on the home testing and the advantages of that moving forward, right? Democratization of the dengue test eventually. Right. Thank you, sir, for your time and effort.
Thank you.
We look forward to you for our next session coming up. Ladies and gentlemen, coming up next Friday at 4 p.m., same time. This is your host, Arjun Mahajan, signing off. Thank you, and everybody. Jai Hind. Good night, sir.